Thank you and welcome back to the Aurora Blueprint, the podcast about bariatric surgery, particularly for patients undergoing surgery with Aurora Bariatrics. I'm joined today by Dr. Jean Palmer, Consultant Anaesthetist, and we're doing a deep dive into the anaesthesia component of bariatric surgery, which is critically important in the perioperative process. So thank you, Jean, for joining us.
Thank you.
To start off with, we wanted to talk about pain, nausea, and rapid recovery. So in terms of pain relief, a lot of patients get very worried before surgery about pain. How do you manage pain during and after surgery?
Well, pain is one of the biggest things that patients worry about. I think it's really important to remember that bariatric surgery is keyhole surgery, minimally invasive, done with very small incisions. So actually the pain fundamentally is not that bad. However, there is always going to be some pain, and we like to manage that really well. One of the things we do is to use a low opiate technique. And the aim of that is to reduce the amount of opiates that are going into the patient so you get less nausea. Having said that, now we've got a hole in our analgesia regime. So we use multimodal analgesia. So I'll actually end up giving you, for a bariatric operation, 9 different painkillers, 2 of which I actually start as you're being admitted, as a pre-med. Okay, so you're actually getting painkillers before you've even had the surgery. So by giving low doses of multiple different painkillers, I can reduce the opiates, reduce the side effects from the opiates, and give you really good pain control. The other thing that we do is that Dr. Ruth will remove all the gas when she removes the ports, and that's a really important thing to do. She will then put local anaesthetic into the port sites, which is where the small incisions are, and then I'll do ultrasound-guided tap blocks or nerve blocks of the abdomen, which will help. And after all that, if you've still got pain, the recovery nurses have got several agents to give you there, and then the ward have also got other painkillers to give you.
Thank you. I actually didn't know how many medications we gave for pain, and no, that's fantastic. The second biggest question would be about nausea and vomiting. So can you run through what you normally do? Because I know, having seen our patients go through this process, they wake up relatively seamlessly. They're relatively free of nausea and they hardly ever vomit. So can you walk us through how you do that?
Yeah, so nausea traditionally with bariatric surgery has been one of the biggest problems. Things have improved. I've been doing bariatrics for the past 15 years and I've been slowly honing my approach. As we've mentioned it before, a low opioid technique reduces the amount of opioids you have. The major side effect of opioids is nausea. So by doing that, we can significantly reduce the amount of nausea. The other thing I personally do is an intravenous anaesthetic of propofol to keep you asleep rather than a gas. Now that's been shown to be much better for reducing nausea and vomiting. We'll also give you 3 anti-nausea drugs while you're asleep. Okay, and then you'll have regular anti-nausea drugs charted for you in the first 24 to 48 hours. So you're automatically getting them from the nurses. You don't need to ask. There'll be ones you can ask as required. Okay, and I'll send you home with wafers of ondansetron so that you can manage any nausea at home. And the other thing is, I often give pre-meds beforehand to reduce anxiety. Anxiety and nausea go hand in hand. So the more chilled out we can get you beforehand, the less nausea you'll have. So if we do all those things, basically very few people have significant nausea and very few people we actually see vomiting.
Okay. So for the patient that's coming up for bariatric surgery, what can they expect to feel or go through in, say, the first 24 hours?
People talk about gas pain with bariatric surgery. Okay, so that's the gas that's been used to insufflate your abdomen to create the working space with which Dr. Ruth operates in. That gets removed at the end, but small pockets of gas take a little while to be resorbed. They can form at the top of the diaphragm and they can cause shoulder tip pain. It's a weird, sharp pain. Now, it's a bubble of gas that needs to be resorbed. The sooner you move, the sooner that gas dissipates and spreads out over a larger surface area and is resorbed. So the more you move, the faster the pain goes away. It's normal to feel some general soreness at the port site. It's normal to feel a bit groggy because you've had a general anaesthetic and 9 different painkillers. It's quite likely at some point you're going to have some mild nausea. You might have a sore throat. Those things are normal and will get better. It is not normal to have increasing pain that's not getting better. It's not normal to have shortness of breath, chest pain or fevers or significant vomiting. If those things happen, we'll be looking for it. But if those things happen, make sure you give us a call.
I completely agree with you about the gas pain. I do try to get as much out as I can at the end of the case, but there's always these pockets. So our specialist bariatric nursing staff on the ward are fantastic in terms of they'll get you little heat packs either for your tummy or for the shoulder tips. And so day one, you'll often have these little heat packs attached to you. It does dissipate, and the best thing for that, as you've mentioned, is time, walking, things like that. So that's great. But how does good pain control and nausea control help with recovery for the patient?
We try to implement the ERAS protocol for bariatric patients, which is enhanced recovery after surgery. So the aim of ERAS is to ensure the patient, by looking at them preoperatively, intraoperatively and postoperatively, you're doing things to make sure somebody returns to the normal function as soon as possible. Good pain control, good nausea control are 2 key components to that. If we give you really good pain control, you'll be able to take a big breath, your lung function will be better. If you don't have pain, you'll be able to walk around better and faster. You'll be able to get rid of that gas pain. If your nausea is well under control, you'll be able to take sips of clear fluids quickly. Your gut function will return to normal faster, and if you're not nauseated, you'll get up and get going. Nausea and pain control are essential components of enhanced recovery.
Okay, thank you for that. Can I ask you some rapid-fire questions which patients often come up with? And the biggest question I get is my patients often have beautiful nails. They're acrylics, they're gels and things. Do they need to remove one or all of them before surgery?
So traditionally, when you came for surgery, you were forced to remove all of your acrylics and nail polish. I can't speak for every single anaesthetist, but in my practice, and I think most people's practice now, we just really want one finger. If you give us one finger, we're happy. Polished nails are fine. Acrylic nails are fine. The only time they're an issue really are when they're really quite long. So if you make sure one finger is short, we're okay with that.
So it's okay if it's short but still has their acrylic and gels and things so they can keep all 10 intact. Perfect. Okay, thank you. What about piercings? Pretty much anywhere.
So we need to know about them. They can stay in. The times they need to come out if they're in the actual surgical site. And if you've got a tongue ring or a nose ring, because I'm dealing with your airway, it's preferential that it comes out. Other piercings will be taped up by the nurses.
And when they are taken out, I don't have a tongue ring, so I don't really know much about it. Do they put spaces in instead or just take it out for the duration of the case?
It's taken out for the duration of the case and you're able to put it back in pretty quickly. We don't really want anything in there which is in your mouth, which has a risk of going into your lungs.
Okay, thank you. And what about medications? Do they take them on the day? Do they bring them in?
If you are on regular medications, bring them into the hospital because otherwise, for me to continue them, I'll prescribe them and the hospital will charge you for medications that you already have. Generally, we would tell you not to have any of your medications the morning of surgery unless your anaesthetist speaks to you, and then we'll actually guide you with exactly what we want you to take. The key things we want to know about are blood thinners and diabetic drugs. So ideally, let us know those beforehand. And most anaesthetists will provide you with an electronic survey to fill out, and you can fill out your medications, and then if there's anything we need to change, we'll contact you.
Fantastic. Okay, are there any other top tips that you could give for patients who are coming up for surgery very soon? So
obviously, smoking and vaping. They are key to improving your healing after surgery. Going through with the diet, I know it's hard. It improves the access your surgeon has to do your operation, so it makes it safer for you. Simple things. I'm always telling people to keep their hands ready. When they're in the holding bay, ready to come into theatre, make sure your hands are really warm. I get people to stick their hands under their bum or in a warm blanket, because by warming up your hands, it dilates the veins. They're much more visible to me. It's much easier for me to put a drip in for you. And if it's much easier for me, it goes in first time, it's painless. After surgery, we want you to get moving as soon as possible. It's really important. It reduces your pain, it reduces your risks, and you'll feel a whole bunch better. And then finally, I think it's really important that you relax. I can help by giving you pre-meds. And if you're particularly anxious, make sure you contact my rooms and we can talk about it and I can put a plan in place. But I routinely give you a pre-med beforehand, which will relax you and also provide you with pain relief when you wake up. But I think it's also really important that you've chosen a surgeon who deeply cares about you and your recovery and will do the right thing by you.
Okay, thank you very much for that. I think that was a very comprehensive and helpful overview. I hope that answers a lot of the questions that you might have in the lead up to surgery. If you do have further questions, as Dr. Jean said, he's very happy to be contacted via his rooms. He will do a consult with all our bariatric patients before the surgery anyway, and you get to meet both of us on the day of surgery before you go off to sleep. Jean, thank you very much for your time today. I really appreciate it.
Thanks very much, Ruth.